Rick Olderman, welcome to the Pain and Performance Podcast, man. I'm glad to have you on.
I'm excited to be here. Thanks for having me, Derek.
I'm gonna kick this off with kind of a ridiculous question in one way, and I think probably one that you have dove into more than most people. So, what is pain?
Pain is, I mean, from a physical therapy standpoint, I see pain as a signal that something's wrong. And usually it's a signal that something's wrong right now. And often, if you can solve most of those things, at least from a musculoskeletal system standpoint, your pain will go away very rapidly. So, ongoing pain or chronic pain, which is what I have kind of seemed to have specialized in these past 25 years, is really a signal to me that these people haven't found the right information yet. And so that was my guiding principle with my patients, is that, look, if you're still in pain, we haven't discovered the right thing yet. And that's what kind of drove me to discover all of these things that I've been looking into the past 25 years.
Yeah, I feel like pain has gotten kind of this unnecessary negativity over the years. Like it's such an important signal in health, and yet I feel like it gets bastardized and kind of demonized a lot whenever we're talking about what we should do in response to pain. So you saying, it's a signal that our body is sending us, I think is a lot different way of thinking about it than what a lot of people would answer that question with, right?
Yeah, exactly. And this is the interesting thing, is the brain is receiving that signal, right? But the brain isn't capable of understanding why that signal is being transmitted. And so that's what we have to do as practitioners, is solve it, because the body is just saying, hey, something's wrong here. I don't know what it is. That's really what's going on. And so that's, sometimes you need outside help to figure these things out.
Yeah, that's the big kind of, I don't want to call it an argument, but the big discussion that we get a lot is like, you have the people who are like, pain is always an output of the brain. So let's just address that part of it. And then you have the other people who are saying, well, pain is always a response of the body. And, we're trying to create this dichotomy that I think in reality probably doesn't exist in our normal physiology. So we're sitting here and kind of arguing back and forth. And the only person who's getting the brunt of this is the patient, who's sitting in between saying, just tell me what to do to get better.
Exactly. Yeah.
Let's take a step back a little bit. So tell us a little bit about your history and how did you kind of come to health and take the steps to maybe kind of change your career a little bit?
Yeah. So, I had back pain when I was in my 20s, and I saw a physical therapist for that, and he helped me in a couple of sessions, but it came back again. And I was thinking about going into PT school at that time anyway. So I thought, wow, intuitively I felt something I'm doing is causing this back pain, right? And so, his treatment, while helpful, didn't solve it, obviously. And so I thought, I'm going to go to PT school and figure out these insider secrets. What's going on here? And it turned out that they never arrived. I was never taught the insider secrets in PT school, because really the focus is on understanding the structures that are painful and treating those structures. There's nothing that talks about why those structures are painful. And so that bore out after I graduated and got my first job. I was good with sprains, strains, post-surgery, pre-surgery, all that kind of stuff. Any kind of chronic issue, it was hit or miss whether I could help someone. It was very frustrating for me as a physical therapist, and intuitively that same guiding principle was that something these people are doing is causing this chronic pain, and I don't know what it is. And, I took lots of continuing education courses. None of them focus on the reasons these tissues are damaged. We got 1 million tests and scans to figure out which tissue is damaged, but there's not one that talks about why it's damaged. And so that's what kind of, spurred me and my search to figure out what's going on with chronic pain. We have to figure out the whys.
Was there something that kind of maybe turned the light bulb on for you, that maybe something else was going on in those cases? Was there, books? Was there something outside of the profession? Was there a course where you were just like, maybe there is something that I'm missing here?
Well, my failure as being a PT was the signal that I was failing, right? So, that was telling me, anytime someone's not getting better, it means I'm missing something. And that was my guiding principle working with my patients these past 25 years. And so my thinking was, I was just like, well, if I believe that's how we're moving or what we're doing with our bodies has something to do with pain, who out there have I ever heard of who is researching this? And so I remembered one of my classmates was really big into Dr. Shirley Sahrmann out of Washington University in St. Louis. And so, I ordered her textbook. I read it cover to cover, and I was just like, holy moly, this is exactly what I'm looking for. I took all of her courses, and I became friends with a PT who happened to be taking all of her courses too. And over the next couple of years, as we happened to have finished the same courses at the same time. And I said, hey, how's this information going for you? And he said, I said, what are you talking about? My patients are getting better. Things, back pain, neck pain, whatever. I'm getting amazing results. He says, yeah, but I'm a manual therapist. So, maybe I'll use this as a home program or something. I said, and that's when I realized that our belief systems in medicine are filtering out information that could potentially be helping our patients. And that's actually the moment I realized I needed to first write my books. And so that's when I wrote my books and I thought I'd do an end around the practitioners out there and take it directly to the people.
Yeah, it's such a big thing, and I feel like in healthcare, it's probably worse or more prevalent than in anything else, is that we almost fight against the progress because of like the programming that we got in school, that we needed to be the ones that fix things. Like that, that's probably kind of this self-fulfilling prophecy. The people who end up going towards that have an inclination to want to be helpful and help other people. And,
yes.
Then there's also the ego that gets attached to like being the one that provided the solution or the hands-on fix to it. And kind of goes back to the same thing. Like, are we slowing down the progress that the patient could be getting?
Right. I absolutely agree. There's huge ego in medicine, And those of you listening out there, don't think it's not so, because a lot of us are trained that we should be the ones to solve the problem. And this idea that guiding a patient, of course there's manual techniques and things like that involved with restoring function. But ultimately, the patient is responsible for their own body. And ultimately, they have to learn what to do. And so that's this whole system that I've created over these past 25 years. And then, I own my own sports and orthopedic clinic here in Denver for about 10 years. And what I realized, and I wouldn't let any of my therapists work at my clinic unless I trained them in my approach, because I needed to test my approach. And so, they were all able to get the same results that I got. Even if they were brand new grads, within 3 months, they were solving really difficult chronic pain, complex issues, because they understood how the body worked. And so owning my own clinic, what that helped me see was, I have all the stuff in my books. And like, if you look at my back pain book, I've got maybe 80 different exercises in there to solve all sorts of problems from no matter what might happen, right? And but owning my clinic and seeing a huge volume of people, I realized that, these things are happening in patterns. So the same pattern of problems that's causing maybe back pain in you is causing sciatic pain in someone else, or SI joint pain in a third person, or hip pain in another. And so so I was able to simplify the approach, because I'm just like, I don't need all this extraneous stuff. It's the same pattern. If I solve this pattern of issues, we solve the problem, no matter how it's manifested in different people. And that's what my home programs are doing.
We're going to double click on a lot of this stuff. I'm excited to dive into some of this stuff.
Yeah.
And really kind of get into, I think, questions that a lot of people have whenever we start looking at identifying the source of their pain. Like, where is my pain coming from? And why hasn't anyone found it? I'll give a quick anecdote, and I want to get some information from you on like treating, the source of and finding the source of pain. But I had a patient who recently, she had an injection into her SI joint because they said the pain was coming from there, and she got no relief from it. And then they did a second injection to the SI joint, and she got minimal relief. And at that point, the physician said, look, I can see on imaging that this is unhealthy. We probably need to do a fusion to the SI joint.
Oh, gosh.
And so she did the fusion to the SI joint, and of course got no relief from it.
Yeah.
And ends up in my office and trying to figure out why all these treatments failed. And that's unfortunately not an uncommon story, right?
No.
We're treating the image. We're looking at, this static picture of the body and trying to identify why pain would be coming from that. So let's dive into that a little bit. What's the difference between pain that we feel and, let's say, tissue damage or imaging discrepancies?
Well, I'm not going to argue with whatever was on that image. I don't know, was it an MRI or was it an X? Yeah. MRI. Okay, so I'm not sure what they saw on an MRI that made them do, and this is, folks, this is classic medical thinking. I believe it's the SI joint. Let's inject that. Did it work? No. Oh, well, it must need a second injection. Why? But let's inject it anyway, right? Oh, that didn't work. But I believe that it must be the SI joint, so we have to fuse this, right? If you already had 2 trials of things that proved that that wasn't the source of the problem, why would you keep going down that road? And that's, to me, that's a practitioner who has one hammer and is seeing everything as a nail, right?
Right.
So pain in this situation, maybe it's coming from her SI joint, maybe it's not, but whatever those interventions were, they certainly weren't going to solve it. So her pain is legitimate. The solutions were not for her. And I can go into what I believe is what I typically see in these kinds of cases, if you want to see what my take is on what was going on.
Let's dive into it. Let's get practical.
Okay. All right. So I've got my little skeleton here.
Love it.
So this is the SI joint. Here's the ilium. Here's the sacrum. Where they meet is the SI joint, sacroiliac joint, right there. So she had 2 injections there. So there's so much. This is a kind of a crossroads of function in the body, right? This is where lower body mechanics translate through the pelvis to operate into the lumbar or low back area. So there's many, many things that can go wrong with this. So you saw her. Did she happen to have an elevated pelvis on one of her sides?
Significant.
Yes. Yeah. Was it on the same side as the SI joint pain?
It was, yes.
Okay. Did you happen to check her rib cage? Was it lower on the same side?
Correct. Yes.
Yes. So she had a right side bending. It was the right side?
It was the right side.
Yeah. So she had a right side bending problem, which is an elevated pelvis on one side and a depressed rib cage on the other. This is a response to some problem in the leg. So this goes into a little bit of our hardwiring as humans. We are born with some major reflexes that help us grow as children. One of those is the Landau reflex, which allows us to lift our head so that when we're crawling, we can see where we're going. It also helps us stand up. So it involves arching the spine like this and becoming more alert. But the reflex that likely is happening in her case is called a withdrawal reflex. So when we're born, and you can watch videos of this on YouTube, you put a baby's foot down on something unpleasant and it will withdraw that foot from that stimulus. But it's not just lifting the knee to withdraw that foot. It's contracting through the whole right side of that body to withdraw that foot, which includes these waist muscles. So the waist muscles that attach to the pelvis to lift that up are the same. They attach at the rib cage, so they're going to pull it down too. And this is a subtle thing that happens in our brain. So as we grow, we override these reflexes because we can't go through life reflexively responding to every stimulus out there, right? So our brain overrides these, but they still are hardwired into our bodies. So on some unconscious level, when there's a problem down here, your brain is saying, oh, I've got to get off of this. And it taps into that withdrawal reflex pattern, which causes this elevated pelvis and the depressed rib cage. Well, what this can do, clearly, because the sciatic nerve roots are exiting the spine here, is that it can compress the sciatic nerve roots, right? So there are other things that will also cause that too. And one of those are tight thigh muscles. So the thigh muscles in the front attach from the knee area to the front of the pelvis. And when they're tight, they will pull the pelvis forward. Now, if they're tighter on one side than the other, that's an asymmetrical pull through the pelvis. And now it's creating torque across the SI joints. So the brain is sensing something going on here, and it lifts that pelvis because it's being pulled down, right? So this is probably what's going on with her, is that she has an old injury on the right side. Probably she may, I don't know, may have tight thigh muscles asymmetrically also. But this is all responding to an older problem down here, would be my 2 cents, given that I haven't even seen her or looked at her. That's how I tend to look at it.
It's awfully. I mean, it's like you're looking at her, and we've worked through a lot of those things, and it brings to mind what we talk about is like the pain is just the signal that there's a problem there. The pain is not the answer of what the problem is.
Yes.
That is a needs more detective work. And the brain actually doesn't really want to do that work. Our brain is kind of saying, hey, here's the problem. I got the signal. I'm relaying that to you. Whatever you're doing that is causing this, that's why I'm sending this helpful signal to keep us alive and keep us functioning. You figure that part out and kind of fix it. I think this is kind of a little bit different, but I think we probably intuitively had more information about how to fix that at some point as beings that we have lost because we've gotten so good at ignoring our bodies, and even not just ignoring, sometimes purposefully taking things to cover up the signals from our body. But when you're looking at it from a source standpoint of kind of, okay, the pain's giving us the signal. I love the way you kind of work through some of that, of where is the pain actually coming from, or the problem that's causing the pain coming from.
Right.
What are some of the things that I think could highlight for people, maybe like where that actual problem is?
Well,
practitioners included.
Yeah, this is the funny thing is, I see this pattern, and let's say I've had my history that I took with my patient, right? And they don't go into any history of lower body problems. And I find this pattern, I'm just like, well, this pattern is happening for a reason. So tell me more about I don't have any older injuries. Well, I'm sorry, your body is telling me something else. And only after I really push, because what happens is we are not trained as, no one has taught us that our injuries, old injuries, can relate to these new pains. And so we are completely dissociated from that possibility. So I had this conversation with a woman via email. She was having, I think it was sciatic pain, I think it was sciatic pain. So anyway, I said, do you happen to know whether your pelvis, oh yeah, I've been told I have a leg length discrepancy. Okay, well, we can unpack this. This is another big, huge medical myth. But anyway, and I'll go into that if you want to. But anyway, I said, oh, okay, so if you've got a leg length discrepancy, is it longer on the side that you're having pain on? Yes. How did you know that? Well, because you've got a side bending problem is what's likely going on. I said, tell me about your old injuries in your leg. Oh, I don't have any old injuries. And I said, oh, I'm sorry. And I haven't even looked at her. I said, I'm sorry. I'm going to disagree with you. You do have old injuries here. You just are not thinking of them right now. And we went back and forth a couple of times. And then finally she goes, oh my God, I can't believe I forgot. I've got this old groin strain and hamstring injury that I've been dealing with for years on that side. And she said, you think they're related? I said, absolutely. Whatever is causing that groin strain or hamstring strain that you're having a problem solving, it's now manifesting as sciatic pain. because your body is saying, hey, I've got to get off of this thing some way, right? And so she's going down that road now to try and figure those things out.
So why do you think that like certain people with some of these issues end up where the pain is chronic and other people get the same signal, but for whatever reason, they're able to adapt to it, they're able to change, and it was an acute problem they had, and then they move on with their life?
Yeah, well, we're seeing a snapshot in a point in time. But just because they're over that now, I mean, I've just seen hundreds of patients with old injuries that are manifesting later. So even though right now, or maybe for the next year, your pain is fine because you've learned to compensate around it, right? Eventually that compensation pattern is going to break down. And so in my opinion, it's really a matter of time. Or it could be that maybe you've changed your usage pattern and maybe you're not working out at the gym 5 days a week anymore or running, 12 miles. And maybe you're running 2 miles and you're not working at a desk anymore or things like that. So if you've changed your lifestyle, that's another way of getting around these things too, because you're not stressing the tissues anymore or the system.
Yeah, it's interesting because we see that all the time as well, where, someone says, I stepped in a hole and had, this 3 days of severe pain a decade ago. But it hasn't bothered me since. Why would it be contributing to this back pain problem that I'm having now? And I think in part that compensation pattern that comes after we have an injury, if we're not careful, can start to really get deeply imprinted in our nervous system and start to cause problems at some point. At what point, we don't often know.
Correct.
But how, so let's do two things. What are some of the major compensation patterns that you see, and what happens when those are asymmetrical?
Yeah, so the biggest thing around back, sciatic, SI joint pain, and any lower body chronic issue, the primary pattern, the habit pattern that's wrong is the gait pattern. So, and what happens typically with gait patterns is that people tend to learn to walk with their knees locked. And when that happens, it shuts off the gluteal muscles, the butt muscles. So the butt muscles are right here in the back of the hip, all right? And they run from here, the sacrum, to the hip bone. Well, they're the primary controller of the tracking of that hip joint. And when the butt muscle isn't turned on correctly, then the tracking issue occurs, and we get excessive hip breakdown, labral tears, FAI, which is femoral acetabular impingement syndrome, arthritic changes, bursitis, piriformis syndrome, all sorts of things. So then what happens suddenly is that your brain says, oh, that's kind of hurting. I'm just going to do this. I'm just going to pull that hip up a little bit, that pelvis up, and get off of that because that's not feeling so good. And then we start to develop this pattern. So, but the original issue is a gait pattern issue. And people start locking their knees more. There's a couple reasons. One is because we have shoes that allow us to lock our knees more. So if you don't believe me, walk around in your tennis shoes for 5 minutes in your house and then walk around without your tennis shoes on in your bare feet. And you'll notice that you're walking differently in your bare feet than with your tennis shoes. So that's one thing. The other thing is, as we get older, our body is constantly looking for more efficient ways to move. And one of those efficiencies comes from locking the knees. When you lock the knees, now your joints are supporting you instead of your muscles. And so then weakness ensues, or tight quads, and the glutes get turned off, and all sorts of things. One of the things I get when I ask people, when I fix their gait patterns, the first thing I get them to do is unlock their knees, because if they don't unlock their knees, we'll never fix anything. And so invariably the complaint I hear is, gosh, my thighs sure are tired unlocking my knees. I said, yeah, so you're getting a great workout now, So this is part of the problem, is that you've, missed that.
And one thing just to kind of point out that you mentioned is, whenever we have a functional gait problem, a functional gait pattern issue, where someone's locking their knees, they're kind of compensating, their pain may manifest as SI joint pain, sciatic pain, low back, hip pain, hip impingement, the snapping hip that everybody kind of talks about. And that collection...
knee pain,
yes.
plantar fasciitis, heel spurs, all down the chain.
Yeah. And that collection of symptoms that your brain is telling you could, and I think this is what you're saying by simplifying it, could all be coming from the same functional pattern problem or functional gait problem that we fix in a similar way for a lot of people. And it clears up this host of, whatever we mentioned, 10 different problems. But we have to go at the functional compensation and gait deficit that they have to correct those.
And I'll tell you, it's so easy to fix. It's so easy. It's ridiculous. I've taken gait courses before, and they make it so complicated. Oh, my gosh. It's not that hard. It's so much easier than people think. To solve gait patterns. It's not rocket science. If I figured it out.
Let's dive into that a little bit. Okay. So we're unlocking the knees. So like if somebody's walking, do you feel, how do you explain it to people to unlock their knees? I mean, I know, that we want them to be bending the leg more, that basically unlock and don't land on a straight leg. But what's the feeling that they're searching for? Yeah,
I've learned over the years that no matter how much I explain it, they're not going to get it. So what I just do is I put a little piece of tape on the back of the knee. I just have them bend their knee a little bit, put a little piece of tape back here, and then I said, now straighten your now walk like your old way. Walk. And when they knock into that tape, they're just like, oh, that's really pulling on my knee. I said, good. Your job is not to let that pull on your knee. So in 3 days, they change that habit, right? Then we can go into the second part of gait training, which is getting the correct muscles to fire at foot strike. And that, again, very simple to do. We love in medicine to make things really complicated, but it's about simplifying things, because you're never going to get your patients they're not going to want to think about 10 different things during gait, right? To fix, I've got to do that. And then, okay. And then what ends up in medicine, I'm sorry to say, is that a lot of people tend to pick on something that the patient absolutely cannot fix. Oh, well, this is why you're having pain. Well, you can't fix that. So that's not my fault.
Yeah, easy for us to unburden ourselves from that. Well,
by picking on something. Oh, your core is still weak. Oh, I'm sorry, your core still isn't strong enough. Gosh, you've been doing this for 6 months. That core still isn't strong enough, and this is why you're having back pain. I'm sorry, I don't even do core strengthening for back pain, because that has almost nothing to do with back pain. So, anyway, regarding gait. Once the knees are unlocked, the thing that we have to do, the biggest thing that needs to happen during gait is that at foot strike, the butt muscle needs to turn on naturally, because it is controlling the whole pelvis and the lower extremity function. That butt has several functions. We mentioned already that it controls the tracking of the hip bone in the socket, but it also controls the femoral rotation at foot strike, right? And so that femoral rotation, when you control that, well, that's half the knee joint. So if you're having knee issues and your femur isn't controlled, well, this is going to cause knee issues. And believe it or not, if you control the femur, then it also controls the foot. So fixing one problem solves so many things down the whole chain and up the chain. Because now when the butt muscle fires at foot strike, it controls the pelvis. The pelvis is no longer being sloppy in its gait pattern anymore. It's something that's controlling it now. And if the pelvis is controlled, guess what? The low back then is controlled. So it's that simple. So you got to get the butt to turn on at foot strike, which is, it can't happen if the knee is locking. Once the knee is unlocking, that part's really easy.
Is that just like cognition, just like practice feeling the butt muscle contract whenever you're propelling yourself forward?
Yeah, so it's the butt isn't propelling us. It's absorbing eccentric deceleration. And it's controlling the body at foot strike. So really what I get here's how I do it. Folks, you can try this at home. All right. So put your hands on your butt muscles. And when I say on your butt muscles, I don't mean at that gluteal crease where your hamstring is meeting your butt. I mean right in the center of your butt, right? Right in the meat of the butt muscle. Now contract your butt muscles together, and there's your maximum contraction. Now relax those. So first I'm going to show you that your butt muscles are not firing. So now keep your hands on your butt. Don't try to contract them. Just walk normally for like 10 steps. Do you feel any of that contraction happening when you're walking? Almost everyone listening will say no, right? Because they're likely locking their knees and they've trained their butt muscles not to fire at foot strike now. So now we're going to change that. So let's assume that you've now fixed your knee locking problem. So the easiest way is if you go up on your tippy toes and you walk around on your tippy toes, keeping your hands on your butt, you will feel that the butt muscle is turning on at foot strike when you're on your tippy toes. All right, so walk around like that for 10 or 20 steps, and then slowly lower your heels back down. And if you take another 10 or 20 steps, you should feel that the butt is now turning on naturally. You don't have to think about this, because if you're thinking about turning on your butt, what happens when you see someone that you know across the street and you say hello? Right when you wave your hand, your butt muscle will turn off, right? So we need to get your gait to turn that on naturally rather than you cognitively turning that on. So anyway, so this is the easiest way to fix the butt turning on. And so the butt doesn't have to be a maximal contraction. It only needs to be about 5 to 10% of your max contraction. We don't need, a ton of force to control everything. We just need it turned on a little bit because of the architecture of that muscle is such that it allows just a little bit of activation goes a long way. And so that's the easiest way to do that.
Yeah, that's brilliant, especially for so many people. We talk about like hip tracking, shoulder tracking. Our environment has changed so much that certainly we sit a lot more, but I think also our functional necessity has changed where, we can get a lot done without being functional these days. I mean, you can pretty much sit on your couch and get almost all aspects of life handled for you. Yeah. So that creates all of these problems where everything is so much in front of us. We're not using a lot of these extensor muscles to keep us upright nearly as much as we used to. And so we start to create this bad asymmetry where everything in front has tightened and shortened to a degree. And a lot of the righting muscles, a lot of the muscles that get us upright have gotten very weak. And that functional problem manifests in all the different pain problems that we talk about. What are some of the ways that people can start to correct some of those functional issues? I love that with the hip because we're turning that on, we're pulling that hip back, we're keeping that balance in there as we're moving. What do you see whenever you're looking at shoulders? What do you see when you're looking at necks that really can help kind of do a similar functional correction, if you will?
Okay, so first of all, I want to go in. So what we've talked about so far is just what I call a side bending problem, which is causing unilateral back pain, sciatic pain, SI joint pain, hip pain, things like that. But the second, even more common pattern that's causing almost all back pain is called an extension problem, which means that either the back is too arched or there are too many forces trying to pull it into an arch. So the thinking of this is that, these might be weak, but there's actually something else going on here. So I'm going to take your listeners through one little test to figure this out in themselves. All right, so everyone just lie down on the floor with your legs straight and feel what your back feels like when your legs are straight. Floor, it can be on the couch or your bed. Usually a firmer surface is a better surface for this test. So your legs are straight and you're feeling your back. Okay, now I want you to bend your knees so your feet are flat on the floor and feel which feels better for your back, knees bent or legs straight. Or if you don't feel a difference, go ahead and hug your knees to your chest so you feel a difference there. So Derek, what do you think? Which position would they feel most better in?
The vast majority, either knees bent or hugging the knees.
Absolutely, right? Okay, so now that we know that, so what's happening when your legs are straight versus when your knees are bent? Well, the easy answer is that, when I bend my knees, my back is flatter against the floor, right? And when my legs are straight, my back is more arched. And you can test this out on the floor and feel it for yourself. Just put your hand underneath your low back and you'll feel that difference. So, but the mistake I think a lot of people make is that, oh, so when my back is flatter, I need to get my back flatter. Well, no. What this test is really showing you is that the leg attachments from the muscles of your legs into your pelvis are affecting your back. And so when they are tight and you are like these thigh muscles and they attach to the front of the pelvis, when they're tight, they're causing your back to arch more. Now the arch may not actually be more, but the force of that arch is still felt at the back. It would be like me pushing on your shoulder as hard as I can, and even though I can't budge you, it doesn't mean that there's no force acting on your body, and your body isn't tensing up to resist that. And that's what's going on with these forces coming from the legs. So what this is telling us, this little test, is that it's the legs that are affecting your back, not the shape of your spine. The shape is being dictated by the muscles from your legs. And so now, if all of you stand up and listen to the rest of this podcast, you'll notice that within the next minute or two, you're going to notice that your knees start to lock, right? And this, again, is an energy conservation move. So as your knees lock, you'll notice, go ahead and feel this, stand up and lock your knees backwards. And now feel what your back feels like. And now slightly unlock your knees. It just has to be a tiny, tiny bit. And feel what just happened to your back. Now, if you're not sure, lock the knees again, and you'll feel that your back arches, right? So now we've learned that, oh, my back feels better when my knees are bent on the floor. And now I've learned that when I stand, I tend to lock my knees, which arches my back and causes my back pain. So all I have to do is unlock my knees? Yes, it's that simple. It's that simple. So much back pain is relieved just when I tape the backs of people's knees and get them to stop locking their knees. 50% of back pain is often relieved with people with this pattern of issues. And as you said, it's the most common pattern out there.
Yeah, that's the world we live in, right? I mean, it's funny you say that, because a test that I came up with a long time ago for people to pick mattress type was to just lay flat on the mattress for about, if you can, 20 to 30 minutes, even if you're in the store and people are looking at you. And if you got the urge to bend the knees and to pull them up, that mattress was probably long-term going to be a little bit too firm for you with where you're at right now physiologically. And so people would do it, and they're like, well, I thought I needed a hard mattress if they're a back sleeper. We've heard that. Like, well, if functionally you're extension sensitive and you're pulling that, those forces are pulling you into extension, you're going to wake up every day and say, man, I'm getting good treatment, I'm doing all these stretches, and I wake up in the morning and my back's killing me. Because all night your body is fighting that extension, right? Yeah,
exactly. And so what I always say is, rather than worry about the mattress you're buying, why don't you fix the body that's going to bed? And let's just do that. And usually then the mattress, question falls away. And so I just wanted to comment. So when these muscles are tight in the front of the thighs, they tend to pull the pelvis forward like this. And so the idea then that the spinal extensors are weak. Well, they're not weak. They're just they're trying to work against an excessive force coming from the legs and pelvis. So if you relieve that force, suddenly you'll notice that the spinal extensors aren't really weak. They're just not fighting this force anymore coming from the legs. And it's usually an easy solution for people with or lordotic or a big curvy lower spine.
What are some of the other patterns? Like, let's jump to the upper body for a second.
Yes. Yeah. Oh, this is a good one. So I figured this one out working with a woman with migraines after a motor vehicle accident. And so she was having migraines for years, and I treated her neck just like I always did with all of my patients, and they got better. This was before I figured all this stuff out. And then, so I thought on our last appointment, I thought, you know what? I think I'm just going to just press on her shoulder a little bit to reproduce that accident to make sure that she can really withstand those forces. She had the worst migraines ever after that, the next day. And I'm just like, what in the world just happened? And so what I realized after 3 days of figuring it out, I had this vision. And it was all the muscles of the shoulder girdle system and the neck all at once. And I saw the connections from the shoulder blade into the neck and the head. And I'm just like, holy crap. It's not her neck at all. It's her shoulder blade. And so I asked her to come back in. I taped her shoulder blade into a better position and then fixed her shoulder blade system. Migraine's gone for good after that. So this is the pattern. Most chronic neck pain and headaches, almost everyone is looking at the neck or the head. And just like your SI joint example, I don't care how many injections or treatments you have to that neck, it's always going to come back because the stressor hasn't been removed yet. And if you guys at home want to just Google shoulder blade muscles, all right? And if you Google that, you'll see that, oh my gosh, yeah, look at these huge muscles going up into the head. And then there's this little levator scapula that goes from the corner of the shoulder blade into C1, 2, 3, and 4. This is actually the big culprit because when the bigger system isn't working, this little guy, levator means elevate, it elevates the scapula. It has to go to work in overtime and it's connecting into all of these vertebrae. And this is when those people are saying, oh, I've got pain right here, it's killing me. That's the levator scapula. And it's overworked because your shoulder system isn't working. So that's the secret. That's the big secret behind neck and headaches is almost no one has had anyone address the shoulder girdle system.
Yeah, it's so funny. Our patients see kind of neck pain and shoulder blade and chest and abdominal as this one giant system. Because, you know, as you were saying, you know, what causes the functional issues? As we've started to look at it, and I'd love to get your thoughts on assessing some of these kind of trunk muscles, but I would bet you 50 to 60% of my chronic neck pain patients have abdominal restrictions that are keeping the whole trunk forward. And, you know, all this stuff ends up being connected at some point, right? You know, it just depends on where and why. And especially the ones who've had treatment that failed. If we release a lot of that restriction in there, we teach some breathing techniques, we loosen up the abdominals, and that tension comes off. It's like what you were saying about the back. Now, it's not that those muscles were weak and struggling to keep the head up. It's that they were fighting all of this forward tension and gravity because the head and shoulder and trunk complex was not in a good position. Now they don't have to work so hard and they relax and all the pressure across the nerves goes away. And they're like, so you're telling me that the restriction in my abs was causing my neck pain? Like, well, it was causing the functional position that was
compensations.
Neck pain. Yeah. So let's dive into that a little bit. What do you look at for some of those things? Is there some good tests? I love that you've developed all these little like things that people can do at home to start figuring out how their body's moving, just for the power that it gives us, right? We're taking control of our health again.
Exactly. So I'll give you folks an easy thing to do. So if you have chronic neck pain or headaches, and I believe in almost, I mean, I'm not allowed to really say 100%, but it really feels like it's 100% of people with chronic neck pain or headaches. It's coming from the shoulder. Acute issues are different. Chronic issues, this is the system that's being overlooked. So here's an easy way. So Derek, here's an easy test for you to do with your patients. I developed it. It's called the armpit test. All right. So if someone comes in with you with chronic neck pain or headaches, so you have them move their head around and you get them to feel, look up, look down, and see where, how painful that is, the restrictions, all that kind of stuff. Here's what you do. You get behind them and you put your hands in their armpits and you just lift those armpits up about 1/2 to 1 inch. And most people, right when you do that, they're going to say, oh my God, that feels great. But even if they don't say that, you got to jiggle that around to make sure that they've really relaxed their muscles, right? So that you're holding it instead of them. And then once you get it up there about 15 to 30 seconds, ask them to move their head around again. And you'll see a huge improvement in range of motion and decrease in pain. And so they're going to be like, oh my gosh, most people I do this, they're like, can you follow me around for the rest of the day like this?
It's expensive, but yes.
It's expensive. I'd be happy to though. But anyway, I do this. And then the next part of the test is, okay, now we're going to now that you've got that feedback, and some people will say, I don't feel any difference. Those are the people who have so much tension, they can't let go. So then for the next part of the test is you let it come back down again. And then they feel like, oh my gosh, I feel that weight on my neck already. Now I see what you're talking about. All right. So this is a quick and dirty test to see, hey, is there neck pain and headaches coming from the shoulder girdle? And if it is, boom, you've just, expedited your whole treatment and say, I'm going to fix this shoulder girdle and we're going to be good as gold,
So if people are at home, if they're doing that or they have a spouse doing it or whatever it might be, what's some stuff that people with neck pain can do on their own to help take that tension off and improve the shoulder girdle position and function?
Yeah, well, most of us work at a computer, right? So the biggest problem that most people have, especially females, is that chairs are too big for them, right? And even the ergonomic chairs can't assume the right positions to support the system well. So you've just discovered that your shoulder blade is the problem, right? And by lifting it up and solving the problem, it means that the shoulder blade system is resting too low. It's what I call a depressed shoulder blade or depressed scapula. And there are many reasons we can talk about why this is happening. But at work, an easy way to fix this at work is bring in a couple pillows from bed and you shove them in between your body and the arm of the chair. And you fold them in half and you shove them right there. So now if you rest your arm on that pillow, you'll feel that it's resting maybe a ½ inch higher than normal, all right? And it's a bigger, cushy little armrest. So you have plenty of room to move that arm around to get that support. So you'll notice that if you do this on both sides of your desk, that you'll feel that, oh my gosh, my neck feels much better at the end of that day. Simple solution. Most arms from chairs can't come in close enough to the body to support the arm. So the position that the arm should be in when you're sitting is it should be right here at the seam of your shirt, right? It should be right by, not forward, not back, right here. And it should be resting about a ½ inch higher probably than what it is for you. And you can see where my hand is right now. This is where my keyboard should be. I shouldn't be reaching for my keyboard. Even if your arm is resting on a table, reaching for your keyboard, you've now lost all the support and it's automatically triggering all these muscles to turn on again, which is what the problem is. So you got to make your desk fit you rather than you fit your desk. And so you're going to put your keyboard here, and I guarantee that if you try this for just a day, you're going to feel so much better. And then there are those people who have mice. They work with a mouse, and usually the mouse is out here to the side or away. I solved the guy's 20 years of neck pain just by having him move his mouse close to his keyboard. Gone in a day. He couldn't believe it. So if you do a lot of mouse work though, what I have most people do is, hey, let's scoot your keyboard over to the left a little bit, especially if you're a right-handed mouse person, and bias your work so that your mouse is right here where you need it to be instead of out here somewhere. You're not typing on your keyboard as much as you're using your mouse, so put the mouse front and center instead of your keyboard. All right?
Gotcha.
So those are easy
point
things.
Out, like for those of you who are just listening, the desk position would be if you kind of brought your elbows in and turned your hands over and just had your elbows at like a 90 degree, that would be where your elbows should sit along your body, touching or close to the rib cage. And then wherever your hands naturally are would be where your rib cage is. And if you are just listening, jump on and check out the video. Rick's showing some amazing stuff. So just to point that out. So
simple to solve. And if, let's say you're going home and watching TV at the end of the night and you're sitting on your nice comfortable couch. Well, then what you're going to do is you're going to shove pillows either underneath your armpit to lift up that shoulder girdle system, right? Or you do it just like what you did in your chair and you shove them underneath your elbows so that your shoulder blade is resting a little bit higher. And you'll go to bed with your neck not hurting so much, which means that you'll sleep better through the night and wake up with less pain too.
This is a little bit of a curveball, but you like thinking of it in this way, it kind of reminds me of a lot of conversations I have with patients in that what are other practitioners missing, if you will, whenever they're treating pain, or where is the philosophical issues that a lot of times we're focusing on the wrong things when we're treating pain?
I think the philosophical issue is that I call it component thinking. We are medically trained to think of the body as components. So you've got back pain, let's look at your back. You've got neck pain, let's look at your neck. And so that's our training, because we are trained to identify the tissues. Again, we have a million tests to determine which tissue is hurting. There's no test that's saying this is why. And so that's what we're stuck in. Oh, you've got a disc bulge at, C3. Oh, this is what must be causing your pain, because it happens to correspond with where your pain is. No. What you have to think of is, why do you have a disc bulge at C3? Right? I have no proof that these functional issues would cause a disc bulge, but it only logically makes sense because of Wolff's law in the body that tissues adapt to the forces placed on it, right? So if you have a depressed shoulder blade for 10 years and you're working at a desk and you have poor arm support and you have got the levator scapula coming up and compressing all your cervical spine and your discs, and it could cause side bending and rotation in those vertebrae too, especially if it's an asymmetrical pull, why wouldn't that cause a structural change in your system, right? So don't blame the structural change. It's your body's way of saying, hey, something bigger is going on here that's causing this. Because we don't just spontaneously develop disc bulges, right?
Right. It's so good. I love hearing this, because this is stuff we talk about in my office all the time. In that, and you can even go, what if they did have the fix? What if they had surgery to fix, this disc bulge or low back, they had the fusion. But if the why is not resolved, why those issues were there, the best surgery in the world isn't going to fix it, because the underlying reason why that tissue was getting damaged is still in there. And so pulling across the surgical site, or pulling across, the structures around that. We hear it all the time.
Exactly.
Oh, the one above to break down.
Or below. Yep.
Because we didn't fix the why, correct?
Yes. And so what I refer to this as systems thinking. We're not trained in medicine to think of the body as a system. We're trained to think of it in components. And so what I have figured out over these past 2+ decades is I've broken it down into systems. And so because of that, I've developed 2 simple evals. One for the back and lower body system, one for the pelvis and upper body system. And so when you go through those evals, you see everything functionally that's causing this pain right on the very first treatment. And you've developed a prioritized way of addressing what's going on. So, and by the way, we talked about that side bending problem earlier with sciatic pain. Well, guess what? Since the shoulder blade is resting on the rib cage and the rib cage is depressed, now we've created shoulder blade dysfunction because the rib cage is depressed. So this is how lower body issues over time can cause upper body issues too.
Yeah. We show a lot of our patients these, myofascial planes, these myofascial trains in the body, how all that, compresses. Some of it crosses over. What does that do? Here's how that functionally is changing the body, and how, like you're talking about, recoiling from a foot problem can track all the way up and be causing a problem in the neck on one side or the other. And it's always open. They're like, that dang song was right. Everything's connected.
Yeah, exactly.
You talked about the diagnosis. Can people find that somewhere? Is that something that's available?
What do you mean?
The evaluations?
Oh, no. Well, okay. So I've created an online training program for practitioners to teach them this way of thinking to solve pain. And so it's on that training program. And since we're talking about it, if you type in Fixing You, all one word, FIXINGYOU, you can get 20% off of that. And that program is at healpatientsfaster.com. So those practitioners who are thinking, I'm tired of being stuck. I'm tired of, the same things not working they might work for some people, but they're not working for everybody. Why is that? That's what drove me crazy as a PT. And I'm telling you, and I've proved it with my therapist, it works for everybody. Young, old, acute, chronic, motor vehicle accident, whatever. It doesn't matter. Because this is how the body works, and it's how it adapts to stresses. And you change that, and you start making miracles, which is what I became a PT to do. I wanted to, create miracles in people's lives.
I love it. Yeah. And we'll put links to all that stuff in the show notes for everybody.
Sure.
And look, probably 30 or 40% of our listeners are healthcare practitioners at this
Oh,
point. And so
that's great.
I think a lot of people can get value. Every time we just pick up and layer these things in together, everything gets better. I'm a big believer. I don't find that there's any silver bullets, anything that seems like it's, the one thing is always like, maybe. I think as we start to treat functionally and treat holistically, that's where people really can change their whole life. So I love that of looking at the body, how it's all functioning together. And
it's so simple, Derek. It's so simple. This is the common theme from all of my therapists. It's so much easier. I can't believe I'm getting chronic back pain better so much. It's so easy. Why aren't we taught this? Or neck pain or headaches or whatever.
And that's
easy.
kind of what I was. So what do you tell someone who brings in, one of these MRIs of a lower back that just, has disc bulges up and down the spine, has stenosis in there? What are we telling them about imaging, about the image that they're showing y'all and what they're feeling? And that's such a huge part of this.
Yeah. Well, so what they're bringing in are structural changes in your body, is what I tell them. We can't argue with those images, but because you have those changes, it doesn't mean that that's where your pain's coming from. For instance, if we're doing this little back pain test that you and I did earlier in the podcast with the knees bent, when you bend your knees and your back pain feels so much better, how is that changing a disc bulge? How is that changing the degree of stenosis you have? It doesn't. It's changing the forces that are acting on those things. That's what we're going to be doing together, is eliminating those forces. And when you do, your back's going to feel just as good as it did when you bent your knees. But this time, it's going to feel good even when you're on your feet and doing all these activities that hurt you. That's how I explain it. And they get it because, we show them. We prove it to them by doing these tests and showing them.
What role do you see imaging playing in the pain picture?
Yeah, so when my approach doesn't work, it ultimately means usually one big thing, that there's a structural damage that we can't overcome. I feel like we just went out. Are you there? Are you there?
And you're back. Yep.
Okay. All right. I don't know what just happened there. But so what
Start
the
back
image...
with when my approach part.
Yeah. So when my approach doesn't work, and I'm not saying it works in 100% of the patients because not everyone's bringing me the same types of problems. And then we get an image. Usually when my approach isn't working, it's because we can't overcome the structural change in that body. There's a something that hasn't been diagnosed, or you've got this disc herniation. Hey, we fix all of the stressors acting on that disc herniation, but your symptoms are the same. I think it's a really good idea that you get this surgery now, right? And guess what? Their outcomes, like you mentioned earlier, if you just fix the thing without fixing the systemic stressors on it, it's just going to come back again. But guess what? We fixed all those systemic stressors. So we know that the outcome for the surgery is going to be so much better because there's not all of these forces acting on the surgical site or the levels above or below it any longer.
Yeah, the other question that brings up is like when we're looking at using things like pain medication, to cover up some of these symptoms that people are getting. How do you feel about those, and where should those fit into the whole like treatment picture for a patient or somebody who's dealing with pain?
Well, I have found if someone has been on pain meds and they've been to a lot of different practitioners, I'm not going to, and they've just met me and I've gone through this exam and I'm just saying, hey, this is what's going on. And I have my little skeleton and I explain everything because people get it when you can show them on a skeleton, right? And so I don't expect them to trust me. I mean, we've all run into that skepticism. So I'm going to say, look, you want to stay on your pain meds? You go right ahead. My goal is to get you off of those. And and these are the reasons why you're on your pain meds. So as you get better, what I want you to promise me is that you'll at least talk to me and work with me about reducing your pain meds as you're feeling better. All right? So let's work together on this. And you want to be off pain meds. I want you to be off pain meds. I want you to go through life without pain. So that's the conversation that we end up having. And they're just like, sure, as long as I'm not trying to just rip their safety blanket away from them, right? None of us want to live with pain, but I've got to prove to them that they can trust me. And this is how I do it.
Yeah. It's such a slippery slope, because when we really look at the data, basically what it says, if they study it, is that pain meds don't appear to improve quality of life right now.
Yeah.
When we've taken people off of them and they really are watching them, the quality of life is not better or worse for either group. So if we're in the same camp, regardless, should we be decreasing as a society our reliance on pain meds and finding more and better ways to address pain without them?
Absolutely. And here's the problem, is that we as medical providers have not given these people these solutions, but they exist. That's what my programs are about. I hate to sound like I know everything. I'm not really like that, but I've just seen this work for so many people with such debilitating pain. It's amazing. It's amazing how simple it really can be. So we just haven't done a good job in medicine to help it.
Well, and I think
now.
for a long time we thought, like what you said is so brilliant, that when we show people what's going on, they get it. They do. And we spend so much time on education that people, and it's unfortunate, but we hear it every day. Patients are like, no one has actually sat down and showed me why this was happening. I have not had that happen. And this probably leads into a deeper conversation about how our medical system is set up that we could talk about all day. But whenever we're looking at that, we, as a medical system, have thought that, for lack of a better term, that our patients wouldn't get it. They don't want to know that. They just want the fix. And I don't think that's true anymore. I think people are now getting to the point where they're like, look, I've done the medicine, I've done the injection, I've done the surgery. I want the information. I want to know the why.
Yes. Yeah. So what are you going to say to that first person that you brought up with the SI joint pain? Well, of course you've brought out your pelvic, bone model, anatomy model, and said, here's the SI joint. The MRI says that this is the problem. We're going to get those injections. Now you fuse it. Oh, you're still having a problem? So it's not that we're not explaining it. We're not explaining it correctly. And it's not because of our training is to think, oh, you've got that disc bulge there. Here, we're going to fix all of these things right here, all right? And we're going to, change that disc bulge. Oh, you're still having pain? Well, yes, you've explained it, but the problem is we're not looking at it correctly in the first place. And that's why our explanations aren't working, right?
You've mentioned a few, but I always find it interesting to dive into like where people have picked up some of their information. What are some of the other resources that impacted your thought on pain a lot? What are some of the other teachers or
Yes.
books or guides that have impacted some of this?
Well, this is a great question, Derek, and you mentioned one of them already, anatomy trains. So here's how it happened with how I figured this out. So I took Dr. Shirley Sahrman's work. I saw amazing results as a result of that. However, as you know, as you get better, the next tier of patients starts knocking on your door saying, what about me? And so I found another tier of patients that was resistant to just the biomechanical changes and movement habit changes found with Dr. Shirley Sahrman's work. So then I discovered Thomas Meyer's anatomy trains. I read through this, and I call them superhighways of fascia, running from that helped me see, I see now how these are linked. So it opened my eyes to other possibilities to look to when looking at back pain. Because look, we got this huge fascial thing from the top of our head down to the bottom of our foot, going right through that low back. Oh, maybe I should start looking in the foot a little bit to see what's going on here to really stress on. So then I started getting people better when I started looking further away from the source, right? But then the next tier of patients came knocking on my door, And these people seem to have like a battery that was supercharging their bodies to be locked in these dysfunctional patterns. No matter what I did to correct the pattern, it kept returning again. I'm just like, what? Why is this tension feeding? Why is there tension feeding this system of problems? And so I looked and looked, and I couldn't figure it out, and then finally I discovered Thomas Hanna's work with Hanna Somatics. Unfortunately, there's no research at all to support any of his work. So I was just like, because everything has to be evidence-based, right? So I'm just like, what do I do? And the reason I looked here is because I got a call from one of my back pain patients who read my back pain book, and she was literally suicidal. She was crying. She's considering committing suicide. She's in so much pain. I couldn't help her over the phone. She lived in another state. And so she called me back a month later. She said, my back pain's gone. I said, how did you do it? Have you ever heard of Hanna Somatics? No. They talk about everything that you talk about, but they talk about it in a different way from this brain standpoint. And so I thought, this seems to be what I'm looking for. So I made the leap. The training is 3 years, 9 days, twice a year to get certified in this. But I thought it was so important. I had to learn what they had to teach me. And so then but they don't understand biomechanics like Dr. Sarman, right? Dr. Sarman doesn't understand anatomy trains or this neurological stuff. Anatomy trains doesn't look at biomechanics or the brain. So I'm just like, and they identified the same 3 patterns that Dr. Sarman did and anatomy trains did. So I'm just like, holy smokes, this is it. So then I just integrated it all. And then none of the 3, I think, went deeply into the habits that we have that are causing these patterns to occur in the first place. And that's where I've been drilling down. That was my contribution to this whole system. So that's how I put it all together.
I love it. That's brilliant. You're on the right track whenever, a few experts are finding the same answer and they're explaining it through their own lens. You're like, okay, yes. All these experts have to be at least on the right track. So I'm going to listen. I'm going to pay attention.
Yeah. I got great results with all 3 of them. But then once I integrated it, it was just like everybody was getting better. I'm just like, this is it. And then I had to figure out how to put that into an evaluation form to evaluate the whole system.
Let's bring this back to a little more kind of the practicality for some of the listeners. Yeah. So we talk about the habits that create some of these patterns. I would love to dive into, like, what are some of the habits that people have? You talked about the legs being locked whenever they're moving. What are a couple of other ones that are causing problems that people don't realize?
Oh yeah, that's a great question. So let's go back up. So the legs are and the gait pattern is a huge one for back, hip, knee, and foot. Let's go upstairs a little bit to the neck and shoulder and headaches. So one of the, if we believe, first of all, this is how I explain it to people. Look at the architecture of our skeleton, right? We have all these long bones everywhere, but there's 2 places where we have broad flat bones. One of them is the pelvis, and this is, of course, the center of function for our lower body system and back. The other one is the shoulder blade. It's a very similar bone architecture. So this is also the center of function for upper body system issues, okay? So if you believe that the shoulder blade is the source of the problem, and that armpit test I described earlier is the proof that they needed to feel that, oh yeah, I feel much better. It is my problem. This is where it is, right? So now we've also shown them with that test that the shoulder blade sitting too low is the problem. Why are the shoulder blades sitting too low? Well, if you go to many yoga, Pilates, or dance classes, gymnastics, what you'll see is they're training everyone to have long necks, right? Bring your shoulder blades down and back into the opposite, into your back pockets. Well, what are you doing when you're doing that? You're depressing the shoulder blades, right? And so people grab on because they're yoga, Pilates, gymnastics, everyone looks beautiful, right? They look very strong and good posture and all this kind of stuff. I want to be like that. So they're going to take that home and they're going to do this. Well, they are actually causing their own neck and pain and headaches by listening to this instruction and applying it outside of yoga or Pilates or gymnastics or dance or whatever. So this postural strategy is one of the biggest causes of this chronic neck and shoulder and headaches, is because it's depressing the scapula, which is then, going through all the mechanics that we explained earlier.
So for them, is that either training? Are they exercising shoulders to make the shoulders stay up, or are they just not like trying to do the whole squeeze down and back, improve your posture idea?
So what they're doing is they believe that because their posture looks good and their trusted instructor has told them to do this, that it is the correct thing to do. And so then, like I said, they adapt this. So there's nothing that is taking them out of this position then. Because then you go to work and the arms of your chairs are too low, right? There's nothing that's taking you back out of this position. And then you have people who say, "Whoa, but when I do this stretch and I pull that shoulder down and I stretch like this, that feels a lot better." Well, anytime you have a muscle that's irritated and angry, if you give it a little bit of stretch, it's always going to feel better because it's contracted. It's straining. And that's why. And so what you're doing is stretching that strain, and it feels temporarily better. But unless you want to do this for the rest of your life, you're actually contributing to the problem by doing this kind of stretch, right? Even though it temporarily feels better, long term, you're building the problem.
You're kind of playing into that functional pattern that we're talking about.
So what we have to do is stop this pattern, right? We have to stretch the muscles that have now adapted to become short because you've been training them to be short and contracted all this time, the scapular depressors. And so we stretch those out, and lo and behold, it's not that you have to walk around like this to feel better, right? It's that you just have to not do this anymore. And when your shoulders can just be where they are naturally meant to be, you will feel that your pain goes away.
That's so good. They need to actually target the antagonist, if you will, of, we're targeting where the symptoms are so much on top,
right.
The levator, the trap, where all that tightness is coming from. If we dove into the lat, serratus, all of the probably lower rhomboids, all that stuff, those lower shoulder
pec
depressors, lower pec, that tension release allows these muscles not to fight so much, and the tension in their shoulders decreases and improves.
Absolutely. And if you're not sure if that's the right thing, do the armpit test. That will show you.
The armpit test.
The armpit test.
The armpit test. So let's flip it over. So if those are some of the things that are causing problems that people aren't, what are a couple of habits that people can build into their day, into their life that unlock a lot of these issues at the same time? What is like the top 2 or 3 things that's like the biggest bang for buck as habits that people can do to physically improve? Yeah.
So, we talked about a couple of them. One is gait, right? I can't talk to you about how important that is to solve plantar fasciitis, knee, and we can go into why if you want to. So that's one big one. And just standing, with your knees soft. The other big one is stop creating this shoulder blades into the back pocket idea to create good posture. A long neck, while it looks pretty, is not functional, right? So if you just stop doing these bad things, then our bodies are designed to heal themselves. So when we have a cut, it heals. When we have a broken bone, it mends. All you have to do is remove the obstacles that you've put in your body's way to allow it to heal. These 2 things are biggies. Your ergonomics at work is another one that we talked about. That's huge. Change those. So, and then the last thing, core strengthening is a big deal for a lot of people when they're dealing with back, pelvic pain, sciatic pain. There's a real emphasis on core strengthening. And I think we've got it all wrong because, we don't have to do exercises to strengthen the core if our posture is designed to do it correctly. Our body is naturally designed to activate the muscles it's supposed to activate when we're using our bodies correctly. So the way that I teach core strength is I have people just take a deep breath in, feel that the rib cage lifts, and they've got another hand on their stomach, one hand on their chest, the other hand on their stomach. So you'll notice that when you inhale, your chest lifts, and when you exhale, the rib cage goes down again, and your stomach relaxes. So if you take another breath and you exhale all the way, but you don't let your rib cage fall all the way down, it can fall 95% of the way down, but not that last 5%. You'll notice that the effort to keep that rib cage from going all the way down, that your stomach has just engaged. And it's doing that naturally. You're not having to think about turning it on. It's happening because you're lifting the rib cage a little bit. This is the core holding up posture. This is what all those abdominal layers of muscles, that's what it's designed to do, is to hold up this part of our body. And it will do it naturally if we just lift the rib cage ever so slightly. And then because everyone has tied their shoulder blades to good posture, the second part of this is then to jiggle your shoulders and get them to relax and get them out of that equation. Because what you've done is by doing this all the time to get good posture, you've tied scapular depression to posture. This is why you're having chronic neck pain. Get the shoulder system out. It's not designed for posture. That's what the core's job is.
So good. It's so good. We could dive in, and if people have questions, where can they find you, Rick? We might have to do one of these things where people throw us the questions out and we do kind of like a little quick round two one day. Man.
I would love that. That would be so much fun. They can find me at rickolderman.com, and I have home programs I've created to help people solve their pain using all of these principles. And while a lot of what Derek and I have been talking about may have gone over your head, it's not necessary that you understand all these intricate things to solve your pain. So know that all the things that we've been talking about, if it makes sense to you, I've put the things that correct all these things into those programs. And it's very honed. It's very succinct. There's not 1,000 exercises. There's like 7 to fix back and sciatic pain, But you've got to fix the habits, and I've got that in there too. And then we haven't even talked about taping techniques. So I'm a big proponent of taping techniques because the brain doesn't know how to hold or use the body. And that's why I use tape to bridge that gap until the person learns how to do it themselves. So I have all the taping techniques I have in there too. And if you type in Fixing You, all one word, you can get 20% off. That's all on rickolderman.com, as well as the practitioner's course too.
I love it. And that one was Healing Patients Faster?
HealPatientsFaster.com if you want to go there directly. But if you just go to rickolderman.com, I have links to all that program and all the home programs. And I've got a new book coming out that you can pre-order. And if you want to read chapters from that book or hear me reading the chapters, I've got a few chapters on my website so that you can listen to those and see what my new book has to say.
Rick, I love the mission. I love what you're doing and what you're talking about. That we don't have to be a slave to the medical or surgery kind of system, this sick care, pain care system that we've created. You can take control of some of these things. Obviously, if you need help, that's why people like us exist. But we want to be the small part of help that gets you on the right track, and then you have control of it from there to really make this life and health what you want to make from it. The one question we ask all our guests is, if you could tell people one thing they could do today to get a little bit healthier, what would that be?
Everything is about you paying attention to yourself. And the clues to your pain are found in those activities that cause your pain. So if you just, for instance, if sitting causes your pain, then take a moment to think about what's happening, especially based on our conversation here. Apply the ideas that you've learned in this podcast to what you're doing sitting that's causing your pain. Start experimenting with, and a lot of the ideas that you'll come up with may go against what you've been taught by other practitioners, right? Don't be afraid to break those rules that they've been giving you, because those rules haven't worked for you so far. So don't be afraid to break those rules and experiment with your body so you find what helps you rather than giving that responsibility to someone else.
So good. So good. Rick, thank you so much. I really appreciate it. Everyone, you can find all the links and everything to all of this amazing information in the show notes. Rick, thank you, man.
Oh, I had a great time, Derek. Thank you.
Had a blast. Appreciate you coming on.
No problem.